Hello, my name is Paul Harker Murray. I'm going to talk to you all about lymphoma, both Hodgkin lymphoma and non-Hodgkin lymphoma. My goal is to provide a lecture that teaches to the test. So this will not be a review of all of the current standards of care, but the goal is to talk about the pathophysiology of these diseases so that you can do well in your ABP certifying examination. I am a visual learner, so the majority of the information I'm going to try and share with you today is written down. My goal is that when you review the material with your syllabus, that you need to use a highlighter to accentuate the important parts rather than use a pen to take notes. That will mean that I am reading some of the slides to you, but the goal is that I don't say anything that you can't glean from the slides as they are written. The other thing is that this is a recorded talk, as are many of them. So I'm going to try and talk as fast as I can. So for those of you who can listen fast, have the advantage of being able to get through this more quickly. As you can see on this slide, we are going to include all of the content suggested by the ABP. The structure suggested by the ABP is on the left. The format of this talk is on the right. It's very, very similar and will be consistent between the different lymphomas. And my goal is to really highlight the differences between the lymphomas that would potentially be testable. So there are many subtypes of pediatric lymphomas. There's Hodgkin lymphoma and non-Hodgkin lymphoma. Classic Hodgkin lymphoma includes the histologies listed here, and then nodular lymphocyte predominant is the non-classic Hodgkin lymphoma. Non-Hodgkin lymphomas are listed below, and they are a very heterogeneous group. The fact that they're all lumped together as non-Hodgkin lymphoma is somewhat enigmatic to me because they are very discrete diseases. But we will go through all of these today. A much better way in my mind of looking at lymphomas are simplifying them based on the cell of origin. So they can be immature or mature, and they can be B-cell derived or T-cell derived. So an immature B-cell lymphoma would be lymphoblastic lymphoma. An immature T-cell derived would be T lymphoblastic. A mature T-cell derived would be anaplastic large cell, and then all the rest are mature B-cell derived lymphomas. We separate them based on morphology, immunophenotype, and cytogenetics. So if you are like me, you lump all of your specific diseases together to make you look more important in your clinical practice. So in the age of 0 to 14 years of age, lymphoma are the third most common pediatric malignancy. And in the 15 to 19-year-old age range, lymphomas are the most common pediatric malignancies. You can see in blue the annual rate per million of non-Hodgkin lymphoma, and in red, Hodgkin lymphoma. And you can see that below the age of 10, non-Hodgkin lymphoma are more common than Hodgkin lymphoma. So the crossover age is 10 years of age. These are the malignant cells of classic Hodgkin lymphoma. This is the Hodgkin-Reed-Sternberg cells. You can see it's the typical owl's eye. It's binucleate, has a thick nuclear membrane with pale chromatin and large eosinophilic nucleoli. In contrast, in nodular lymphocyte predominant Hodgkin lymphoma, this is sort of a mononuclear variant of the Reed-Sternberg cell. And you can see this convoluted and irregular nucleus that looks a little bit like popcorn, and they may also have several nucleoli. Within either classic or nodular lymphocyte predominant Hodgkin lymphoma, the neoplastic cells compress less than 1% of the tumor. However, the cytokines they produce determine the signs, the symptoms, and the histology. The Hodgkin-Reed-Sternberg cell does have a number of variations. Here's your classic Reed-Sternberg cell with the binucleate owl's eye appearance. Here's the mononuclear Hodgkin cell. Here's a multinuclear variant. And then these are called lacunar cells because they look like little islands because the cytokine has been pulled away. And this is just an artifact of formalin fixation. The first histology we're going to talk about is nodular sclerosing Hodgkin lymphoma. These can be visualized grossly because they have a thick capsule with thick sclerotic collagenous bands. And you can see that here as well. And you can see these collagenous bands surrounding distinct nodules. This is the most common classic Hodgkin lymphoma. It often involves the neck and the mediastinum. This is mixed cellularity Hodgkin lymphoma. Here you see the Reed-Sternberg cells, but now it's surrounded by lymphocytes, eosinophils, plasma cells, and histiocytes. It's the second most common form of classic Hodgkin lymphoma. It's often seen in patients less than 10 years of age, and Epstein-Barr virus is frequently involved. Disease is often advanced at presentation, but here you see the lymphocytes, the histiocytes, the eosinophils, so mixed cellularity. This is lymphocyte-rich Hodgkin lymphoma. Here's your Reed-Sternberg cell. And then you see these sheets and sheets of small lymphocytes. And this can be nodular or diffuse in terms of histology. Here's another example of lymphocyte-rich. Here's your Reed-Sternberg cells. And then here are the sheets of lymphocytes. Sometimes the Reed-Sternberg cell can look like non-classical nodular lymphocyte-predominant Hodgkin lymphoma. And then this is lymphocyte-depleted Hodgkin lymphoma. We see these large, bizarre malignant cells, few lymphocytes, disorganized fibrosis, and here's your Hodgkin lymphoma cell. And this is very rare in children. It's usually adults with HIV, and it's almost always EBV positive. Then finally, we have nodular lymphocyte-predominant Hodgkin lymphoma. Here you can see the nodules. And then up close again, the malignant cell looks like popcorn with several small nucleoli. We also use immunophenotyping to distinguish between them. This is staining specifically for CD30, and classic Hodgkin lymphoma is positive for CD30, whereas nodular lymphocyte predominant is not. The thing to remember is classic Hodgkin lymphoma is positive for 15 and CD30, whereas nodular lymphocyte predominant is positive for CD45. And the way you remember that is 15 plus 30 is 45. Nodular sclerosing Hodgkin lymphoma is the most common Hodgkin lymphoma histology. It's shown here in blue. This is for less than 10 years, 10 to 14 years, and 15 to 19 years. And you can see that it becomes more common as we age. There are some buzzwords here. So nodular sclerosing, you think about young adults, and EBV is positive in 25%. Lymphocyte-rich and mixed cellularity are more common in patients less than 10 years of age, with increasing frequency of EBV positivity. And then lymphocyte depleted is adults with HIV and almost always associated with EBV. And we'll talk a little bit about nodular lymphocyte predominant in a couple of subsites. Importantly, the histologic subsites are based on the tissue architecture, the fibrosis, the inflammatory infiltrate, but we currently don't use them in risk stratification. So Hodgkin lymphoma may be multiple diseases mediated by genetics, infection, and immune function. So in terms of genetics, if you have a family member with Hodgkin lymphoma, your risk increases significantly based on whether it's a parent, a sibling, a brother, a sister, or a monozygotic twin. So genetics clearly plays an important role. Immune function is also important. Patients who are immunodeficient, like sarcoid, ALPS, ataxia, telangiectasia, and HIV, have an increased risk of Hodgkin lymphoma. And Hodgkin lymphoma patients can sometimes present with a dysfunctional immune system, and they can have ITP, autoimmune hemolytic anemia, autoimmune neutropenia, and nephrotic syndrome. And finally, there's an association with your immune status in terms of infection or lack thereof. So in the childhood form, age 0 to 14, patients tend to have a lower socioeconomic status, a larger family, and perhaps an earlier, more intense exposure to infections. In contrast, the young adult form, age 15 to 35, patients tend to have a higher socioeconomic status, a smaller family house, less siblings, less playmates, and less exposure or later exposure to infections. So this is where the let them eat dirt comes in. Lower exposure to different types of infections may decrease your immune repertoire and predispose you to a risk of Hodgkin lymphoma. In addition, EBV may cause some cases of Hodgkin lymphoma. So many patients with Hodgkin lymphoma have high antibody titers against EBV. The EBV genome is found in and localized to Reed-Sternberg cells. Up here it says the latent membrane protein 1. And LMP1 resembles an activated tumor necrosis factor superfamily member, and signaling goes through the NF-kappa B pathway, which is constitutively active in Hodgkin lymphoma cells. EBV expression varies by subtype of Hodgkin lymphoma, by the ethnicity of the patient who has it, and by population, so more common in younger age and lower socioeconomic status. So this picture is meant to show the pathways that are involved in Hodgkin lymphoma cell proliferation. So we see that NF-kappa B is constitutively active, either through signaling through CD30, through signaling through the EBV LMP1, or if you're EBV negative, you can have an I-kappa B mutation, which blocks the binding of I-kappa B and allows NF-kappa B translocation to the nucleus and signaling through there. The other thing that we know is that cytokines activate the JAK-STAT pathways. And so that increases expression of PD ligand 1 and PD ligand 2, which we'll talk about in a minute. So the purpose of this slide is to show what are the pathways that are driving Hodgkin lymphoma cell proliferation. The other thing to know is what are the mechanisms by which Hodgkin lymphoma cells resist the immune response. So here is a T cell, and we know that T cells are activated by the T cell receptor interacting with a foreign peptide that is presented by MHC class 1, and it signals through ZAP70, etc. And that results in T cell activation, cell growth, effector function, and survival. Well, one is MHC class 1 expression is low or absent in 93% of classic Hodgkin lymphoma. The other thing that we know is that PD ligand 1, program death receptor ligand 1 in the tumor microenvironment is present on Hodgkin Reed-Sternberg cells as well as tissue macrophages. So Hodgkin lymphoma has these 9p24.1 alterations, which result in increased expressions of PD ligand 1 and PD ligand 2. Ligation of PD ligand 1 to PD1, the receptor on T cells, results in T cell anergy, growth inhibition, and inhibition of immune effector function. So think about PD ligand 1 as a crossing guard holding up a stop sign. It's essentially a don't kill me signal that Hodgkin lymphoma cells have harnessed to prevent the immune response. That's the bad news. The good news is that now we have checkpoint inhibitors. These are antibodies either targeted against PD ligand 1 on the tumor microenvironment or PD1 on T cells. And by blocking that don't kill me signals, these restore anti-tumor immunity, and these are extremely active in Hodgkin lymphoma. This is meant to be a review slide. This is the one that you print out and study for when you're cramming for the test. It talks about the malignant cell, the origin of the cell, the phenotype, and then the pathways that are involved, as well as components of the tumor microenvironment that contribute to immunity. Certainly, there's a little bit less information on the nodular lymphocyte predominant side because a little bit less is known, but this is meant as a cheat sheet slide. So in terms of the presentation of Hodgkin lymphoma, the classic presentation is painless cervical or supraclavicular lymphadenopathy. There's a mediastinal mass present in about 2/3 of patients, and they can have constitutional symptoms. The B symptoms listed here are prognostic. So that's the weight loss of 10% in 6 months, the drenching night sweats, the unexplained fevers for 3 days. There are other symptoms which can exist, but are not prognostic. The fever, the anorexia, the mild weight loss, my favorite, which is pain immediately following alcohol ingestion, which I cannot explain the mechanism of. And then you can also have pruritus, which is generalized, severe, and more often an advanced disease. I've had patients who've presented with severe pruritus, and the dermatologist immediately said, this is not eczema, this is lymphoma, and sent them to us. So kudos to them. You can also have evidence of inflammation or reticular endothelial system activation. So high CRP, high SIDrate, high ferritin, anemia of chronic inflammation. And then, like I mentioned previously, autoimmune cytopenias, which are uncommon, but do go away with treatment of the underlying disease. Here's an example of a 15-year-old female who presented with 2 months of cervical lymphadenopathy. You can see a large anterior mediastinal mass, and she was diagnosed with stage 2A classic Hodgkin lymphoma, nodular sclerosing subtype. In terms of the clinical presentation of nodular lymphocyte predominant Hodgkin lymphoma, it is less common. It's only 5 to 8% of Hodgkin lymphoma, but it occurs in, it's 10 to 20% of Hodgkin lymphoma in prepubertal children. Most of the patients are male, have localized disease, no B symptoms, no bulk disease, not systemic, and they're EBV negative. The good news is that surgery only may be appropriate for stage 1A disease. The bad news is 10 to 15% can transform into a diffuse large B-cell lymphoma. The buzzwords to remember are young, male, contained or localized, and asymptomatic. I will not sing YMCA from the Village People for you because somebody will record it and it will haunt me for the rest of my career, but these are the buzzwords for it. So in terms of the evaluation, obviously a history and a physical examination, you ask about B symptoms, you look for lymphadenopathy, you very specifically look for superior vena cava syndrome and superior mediastinal syndrome, which I will mention a little bit later, CBC, chem profile, inflammatory markers. You always do a chest x-ray to evaluate for mediastinal mass prior to anesthesia. You try to do an excisional lymph node biopsy. We look at that for histology and architecture. You certainly can do a core needle biopsy, but an excisional one is better. You do a PET CT, or now what we do at our institution is a PET MRI. This has largely replaced bone marrow biopsy. Previously, we would perform bilateral marrows if they had stage 3 or 4 disease or B symptoms, but I'll explain why we don't do that anymore. And then a CT of the chest to assess for lung involvement because MRIs tend to not be as good. One of the previous test questions was understand the differential diagnosis for an anterior mediastinal mass. I think it's important to know that there are lots of non-malignant causes and there are malignant causes, and not all of the malignant causes are lymphoma. When we do a PET scan is the metabolic study of choice. FDG is a radioactive glucose analog. It correlates with proliferation in cells undergoing anaerobic glycolysis. The drawbacks are you get false positive inflammation, you can get thymic rebound, you can get brown fat. But we use the PET scan for staging at diagnosis. We use it for response to therapy. Now a complete metabolic response is remission. And that's especially useful when there's only a partial response by CT. Remember, nodular sclerosing classic Hodgkin lymphoma has these thick sclerotic bands, so you can have a metabolically inactive node that is still pathologically enlarged because of this more or less scar tissue. This is more sensitive and specific than a bone marrow biopsy, which is why it's replaced bone marrow biopsies. PET scans are not appropriate for off-therapy surveillance for recurrence. Most relapses are detected clinically, less than 12 months from completing therapy. Early detection of relapse does not affect overall survival, and surveillance imaging is expensive and results in unnecessary radiation, so I don't do it. PET CT is used for anatomic localization and staging at diagnosis, and it is more sensitive than bone marrow biopsy it is for Hodgkin lymphoma. And you can see the bone marrow involvement in the femurs, in the pelvis, in the vertebra, and then you can also see the anterior mediastinal involvement as well as the cervical involvement here. Now, PET scan does have false positives. This is an 18-year-old male with glomerulonephritis who was referred to me for diffuse pet-avid submandibular, cervical, axillary, and inguinal adenopathy. And one of the things that you notice about this is that it's extremely symmetric. This is a systemic disease, whereas Hodgkin lymphoma tends to progress from among contiguous groups of lymph nodes. So this patient was diagnosed with HIV, not lymphoma. We use PET imaging to monitor response to therapy. The current standard of care is the Deauville scale, which is a 5-point scale, which is listed here, and I won't read it. In terms of interpretation, 1, 2, or 3 constitutes a complete metabolic response. However, in certain clinical trials, they will only call a complete medical response a 1 or 2 because these are de-escalation of therapy trials and they really want to avoid under-treatment. But in general, a complete metabolic response is anything that is less than the uptake of the liver. This is the Ann Arbor staging classification. It's useful for risk stratification because Hodgkin lymphoma spreads predictably along contiguous lymph nodes until it's very advanced. I'm not going to read it, but please do realize that the substage classifications and the definitions of bulk disease very specifically apply to Hodgkin lymphoma, not non-Hodgkin lymphoma. In terms of prognostic factors, unfavorable factors at diagnosis include advanced disease, B symptoms, bulk disease, and extranodal extension. And then during therapy, a slow or incomplete response to therapy is also predictive. There's multiple cooperative groups that treat Hodgkin lymphoma, and unfortunately, they each risk stratify slightly differently. These are the risk stratifications based on the Children's Oncology Group, which accounts for 95% of pediatric patients treated in this country. But there's also the Hodgkin Lymphoma Consortium in North America, and then there's the German Multicenter Euronet. You don't have to memorize each of these different strata. You do have to understand that higher stage or bulk disease are negative prognostic factors. And then when you combine them, these are the things that each of the groups have in common. So it's probably fair to say if a patient has stage 3B or stage 4 Hodgkin lymphoma, is that high risk or not? Yes, that's high risk. And stage 1 or stage 2A without bulk is low risk in all of the consortia. In terms of treatment, treatment is multimodal, meaning we give multi-agent chemotherapy with or without radiation. Hodgkin lymphoma does not require lumbar punctures or intrathecal chemotherapy or craniospinal radiation. Survival is greater than 90%, even for patients with advanced disease. Therapy is also risk adapted. So disease severity or risk stratification determines the intensity of therapy. So we look at stage and prognostic factors at diagnosis as well as response to therapy. Modifications to therapy may include increasing treatment, decreasing treatment, or removing the modality of therapy such as radiation. Because our cure rates are very high, ongoing clinical trials are designed to minimize late effects. So we're trying to decrease cumulative doses of alkylating agents, of anthracyclines. We're trying to employ less toxic agents. We're trying to decrease radiation fields and give more precise delivery. And now we're also doing targeted therapy. So brentuximab vedotin, which is an anti-CD30 conjugated to monomethyl auristatin E, or checkpoint inhibitors, like I mentioned earlier. So we're trying to work smarter, not harder. This is an example of tailoring radiation fields to protect normal tissues, and I got this slide from David Hodgkin. So in the old days, we did mantle radiation, which was very nice at killing the lymphoma and hitting the heart and ruining the thyroid and hitting the lungs and hitting breast tissue. Then we switched to involved field radiation, which reduced the collateral damage, and now involved node radiation, which treats only the involved lymph nodes. So we're getting better. These are the radiation doses. I don't think you should have to memorize those. Now, data do support elimination of radiation based on staging, response to therapy, and the very specific chemotherapy backbone. These are very specific examples of clinical trials which have successfully eliminated radiation for a subset of populations. The problem, there is no national or international consensus of exactly who should be treated with chemotherapy alone. Another component is treatment of relapsed Hodgkin lymphoma. In general, the therapeutic design have been to pick a novel therapy and give it for a certain number of cycles. And then if they go into a complete response, they go to a high-dose chemotherapy and autologous transplant. If they don't respond, then you do something different. And then secondary goals have looked at complete response, partial response, and the ability to mobilize stem cells. Most retrieval trials in adults have used this model, and the last 6 trials from North American cooperative groups have also used exactly that model. The problem is patients with a late relapse of low-stage disease don't really need an autologous transplant, and a number of reviews have been written on this. The problem with that statement is that there's no standard of care. Patients with primary refractory disease, so either patients who progress on therapy or people who relapse within the first 3 months of completing therapy, don't do well even with autologous transplant. And then the other question I frequently get is, what is the role of post-transplant brentuximab? It seems to be approaching the standard of care for adults with relapsed Hodgkin lymphoma. We are studying it in pediatrics, but we don't have established data yet. And then there's no standard indication for allogeneic stem cell transplant for Hodgkin lymphoma in pediatrics. There are a number of different potential targets for novel therapies. I think these would be fair questions for the examination. Obviously, CD30 for classic Hodgkin lymphoma, EBV-specific CTLs for EBV-positive diseases, CD20 as a target in nodular lymphocyte predominant Hodgkin lymphoma. Checkpoint inhibitors are actively being used to target the microenvironment to make the lymphoma cells less resistant to the immune response. There are some intracellular pathways which are not as well advanced, but the NF-kappa B pathway or the JAK-STAT pathway, or epigenetic modifiers that block histone deacetylation. In terms of late effects, this is just something to remember or study. It can have skeletal, cardiac, pulmonary, endocrine, or secondary malignancies. And as you can see, looking at the potential etiologies, radiation therapy is a culprit, as are the alkylating agents. And then in terms of secondary malignancies, radiation, the alkylators, and the epipodophyllotoxins. This slide is to show two things. One is that in terms of secondary cancers, breast cancer in women is the most common secondary malignancy. It's certainly higher for females who receive radiation at the age of 10 or older, but that risk decreases with age, and there's no excess in patients who are age 30 or older at the time that they get radiation. The greatest relative risk is for leukemia, but that's a relative risk, not a cumulative risk. Okay, moving on to non-Hodgkin lymphoma. Again, we're looking at T-cell derived, B-cell derived, immature, and mature. Now, there's a whole bunch of others, but I'm going to focus on these. But there's marginal zone, follicular lymphoma, peripheral T-cell, NK T-cell. These are extremely rare, and the data that we have on how to treat them is less well established. So, first of all, is non-Hodgkin lymphoma children are highly aggressive, disseminated diseases. These statistics vary depending on which paper you read, but you think as Burkitt is about 40% in diffuse large B-cell, T-cell lymphoblastic, and anaplastic large cell, being about 20% each. And for those of you who have engineering degrees, I realize that these numbers don't add up to 100%. This is biology. B-cell lymphoblastic lymphoma is only about 3%, and then primary mediastinal B-cell lymphoma is only about 1.5%. 60% of these are stage 3 or 4 at the time of diagnosis, and less than 1% are secondary malignancies. Pediatric non-Hodgkin lymphomas are more common in younger children, which is what we're showing here, more common in males, and more common in Caucasians. The incidence is only about 4 per million in patients aged less than 20, so there's only about 800 cases per year in the United States. Burkitt lymphoma is about 5 times more common in boys than in girls. The incidence increases with age for all of them except for lymphoblastic lymphoma. And they're about 3% of cancer if you're less than 5% of age, and about 9% of cancer if you're greater than 10. The etiology is generally unknown, but risk factors include EBV infection, specifically for Burkitt, and immunodeficiency or immunosuppression. And there's some association with pesticide use. The point of this slide is to simply say that immunodeficiencies increase the risk of Hodgkin lymphoma. The associations that I want you to remember are that T-cell deficiencies predispose you to B-cell lymphomas, often with extranodal disease that are EBV positive. The major subsets of pediatric non-Hodgkin lymphoma that we're going to look at are listed here, and I'll go through them one at a time. This is Burkitt lymphoma. There's homogeneous, medium-sized cells with a very high mitotic index, and this is that Van Gogh starry sky. And here are the stars in the skies. This is the bone marrow of a patient with Burkitt lymphoma, or I guess in this case, Burkitt leukemia. Again, you still see the stars in the sky. Burkitt lymphoma is very highly proliferative. This is MIB1 staining, and you can see it's a marker of proliferation, and like 99% of the cells are positive, so very highly proliferative. This is the cheat sheet for Burkitt lymphoma. Boys more common than girls, usually 5-10 years of age. There are both sporadic and endemic forms, which we'll talk about. They have markers of a mature B cell. They are highly proliferative, and the memorizable translocations are MYC translocations. So MYC is on chromosome 8, and then it's associated with the heavy chain on chromosome 14, or the kappa or lambda light chains on chromosome 2 or 22, respectively. But MYC is sort of the defining translocation. Others can occur. Burkitt is the first human tumor to be associated with a virus, to be associated with recurrent translocations, and to be associated with HIV. Burkitt leukemia, so greater than 25% marrow involvement, is treated like Burkitt lymphoma, not like acute lymphoblastic leukemia. Sporadic on the left, endemic on the right. Sporadic is North America, Europe. It has an incidence of only 2 per 100,000. Its patients are slightly older, and there's less of an association with EBV. The endemic form is kind of the malaria belt. Any place where malaria is common, Burkitt is more common. The incidence is about 50 times higher, a little bit younger in age, and much more frequently associated with EBV. The presentations certainly do overlap. Both of them express the EBV latency proteins, and the MYC translocations are the same. Here's an example of a 4-year-old with an abdominal mass who presented with a uric acid of a 14 because he had spontaneous tumor lysis, and a creatinine of 1.3 because he had spontaneous tumor lysis, and he also had renal involvement at the time of diagnosis. So he was stage 3 or FAB-LMB group B. And I'll go over what that means. The diagnosis of non-Hodgkin lymphoma is challenging because the histology, immunophenotype, and cytogenetics overlap. Here you see 2 examples of starry sky. On the left, it's Burkitt lymphoma. On the right, it's lymphoblastic lymphoma. The stars and the sky are just reactive macrophages engulfing apoptotic debris from rapidly dividing cells. So technically, any NHL can have a starry sky appearance. To make everybody's life worse, c-MYC and B-cell markers can also occur in diffuse large B-cell lymphoma and primary mediastinal B-cell lymphoma. Here's diffuse large B-cell lymphomas where you've got large cells, abundant cytoplasm. There's lots of different histologic subtypes, but we treat them all the same. So again, the phenotype, they still have B-cell markers, usually surface IgG positive, usually light chain restrictive. They can occasionally have CD30 positivity. That's a nonspecific marker of activation. About 2/3 of them can express BCL6. About 1/3 express NMYC, and that's not specific. They are a little bit less proliferative than Burkitt, with less than 90% of cells being Ki67 or MIB1 positive. We do have 2 subsets. In pediatrics, most of them are the germinal center B-cell-like, so germinal center-like diffuse large B-cell lymphoma. About 10% are the ABC type, the activated B-cell type, with a T14-18 translocation. The ABC type is more common in adults and has a worse prognosis. The way I try to remember it is adults already know their ABCs, pediatric patients don't. Trying. Presentation is more diverse. So you can have lymph node involvement, liver involvement, spleen, marrow, mediastinal. You can have extranodal abdominal involvement, like in the bowel or the mesentery, and it may present with intussusception, and again, often with advanced stage. Here's a 13-year-old with 10% weight loss, supraclavicular and axillary lymphadenopathy for several months. Here you can see the axillary and supraclavicular adenopathy. Here you can see the spleen involvement, which again you see here and down here. So he was stage 3 FAB-LMB group B. Here's a 13-year-old female with fevers, fatigue, and symptoms of a urinary tract infection with frequency and urgency. You can see that her bladder is compressed by this abdominal mass, and she had a sympathetic pleural effusion. She also had stage 3 diffuse large B-cell lymphoma. Primary mediastinal B-cell lymphoma is a very rare thymic B-cell lymphoma. It compromises about 20% of diffuse large B-cell lymphoma, but only about 1% of pediatric NHL. The gene profile overlaps with classic Hodgkin lymphoma. They share about a third of the same genes. You still see B-cell markers, no surface IgG. CD30 is expressed in 80%. They do express PD-ligand 1 and PD-ligand 2, so it's a potential therapeutic target. And they have low MHC class 2. Like Hodgkin lymphoma, they do have 9p24.1 amplifications, which increase your PD-ligand expression. They do have some C2TA alterations, which decrease your MHC expression. They do have amplified JAK, and then they do also have some IL-4 receptor activating mutations. And by increasing the JAK STAT activity, that increases their cell proliferation. They generally present with an isolated mediastinal mass and respiratory symptoms, and they can have superior vena cava syndrome in about 50% of presentation. Here is an example where you see a very, very isolated anterior mediastinal mass. There's no other PET avidity. There's no other pathological PET avidity anywhere else. Lymphoblastic leukemia lymphoma. You can see here is a lymph node, and the lymph node architecture is completely effaced. Just sheets of small round blue cells, no follicles. Here is up close again. The lymph node architecture is effaced by small to medium-sized cells with open chromatin, minute nucleoli, and the lymphoblasts of lymphoblastic leukemia and lymphoblastic lymphoma are cytologically identical. Again, this is an immature lymphoma, so they have sheets and sheets of TDT positive immature lymphoblasts. When we compare T lineage versus B lineage lymphoblastic lymphoma, about 3/4 are T lineage. 90% of T lineage are stage 3 to 4, the opposite for B lineage. It will frequently present in the mediastinum or the bone marrow, and occasionally the CNS, whereas B lineage tends to be isolated nodes or the bones or the skin. Obviously, the markers for T cell would be T cell markers, and for B lineage, it would be B cell markers, but they do have these immature markers like TDT. In terms of translocations, it's frequently a T cell promoter onto transcription factors for the T cell disease, and B cell disease is less characterized. I can't imagine that they would ask these specific ones, but these are some of the translocations that we see. I wrote 2019, I guess it's 2021. This should not be on the test, but if you are Notch wild type or have a P10 mutation or loss of heterozygosity at 6q, those patients do worse. Here's a 14-year-old female who presented with fatigue, tachypnea, and palpitations. She has T-cell lymphoblastic lymphoma, and she presented with pleural and pericardial effusions and an anterior mediastinal mass. She was diagnosed based on draining the pericardial fluid, which I admit is not the least invasive way of obtaining a biopsy, but she had tamponade physiology, and so the fluid needed to be drained. This is anaplastic large cell lymphoma. Here we see large pleomorphic cells. The nucleus can be horseshoe-like, and this is the hallmark cell, can occasionally be multinucleated. You will also sometimes hear them say with a paranuclear HOF. So this is the paranuclear clearing that you see here. So that's another component that you'll see with anaplastic large cell. The phenotype for this type of lymphoma is negative for CD15, positive for CD30, and that's important because this is a good targetable antigen. They have T cell markers in 60%. The T cell genes are always rearranged, and very frequently they have overexpression of the ALK kinase. 75% have a translocation in chromosomes 2 and 5 that results in an NPM-ALK fusion protein. So NPM is the nucleophosmin housekeeping gene, and ALK is the insulin receptor tyrosine kinase. So the pathway that this triggers is the PI3 kinase or AKT pathway. They tend to present often slowly progressive with systemic symptoms, but they can also have a very highly aggressive, robust inflammatory state. They can present with hemophagocytic lymphohistiocytosis, which has just as many syllables as supercalifragilisticexpialidocious, and you can also have cutaneous involvement. This line is supposed to be up here. The formatting got messed up. But in terms of cutaneous anaplastic large cell lymphoma, they're CD30 positive, but ALK negative. And that's a completely different entity that can wax and wane and can resolve spontaneously and requires significantly less therapy. Here's an example of a 17-year-old with rash, fevers, weight loss, cervical lymphadenopathy, and you can see this mediastinal involvement as well. He had ALCL with cutaneous involvement, not cutaneous ALCL, but systemic ALCL with cutaneous involvement. This is a study slide which compares the clinical presentations of the different types of pediatric non-Hodgkin lymphoma. It's important to know there's a star here. Two things. One is mature T cell lymphoma almost never presents with abdominal involvement. And then intussusception is almost, as a presentation, is almost exclusively abdominal Burkitt or large B-cell lymphoma. In any teenager with intussusception warrants a workup for lymphoma. It's lymphoma until proven otherwise. I thought I was very clever by making an emergency presentation, but the reality is that lymphomas can cause all of the oncologic emergencies. So these are some of the mediastinal things that you may, or I'm sorry, these are some of the oncologic emergencies that you may see, but lymphoma is on the differential for all of them. One of the questions that we sometimes get is, should we sedate the patient to prevent an airway obstruction? And the answer is no. Here's a patent airway in a 17-year-old with primary mediastinal B-cell lymphoma. And you can see that with sedation, it almost completely occludes his airway. And this was mild sedation just for a needle biopsy, so don't do that. The reason we don't intubate for airway protection is that your ET tube stops here, but the airway obstruction is frequently distal to that. And if the only thing maintaining your airway patency is your respiratory drive, turning that off with sedation is a bad, bad thing. Superior vena cava syndrome and superior mediastinal syndrome are medical emergencies. The way you manage them is supine positioning. Supine positioning and anesthesia can place the patient at risk of circulatory and respiratory arrest. We need to do a biopsy. We need to obtain tissue by the least invasive means possible. And so in increasing degree of difficulty, a bone marrow biopsy and aspirate are easiest. You can do that awake with local anesthesia. You can do thoracentesis if they have a pleural or pericardial effusion. And you can do a lymph node biopsy or a CT-guided core needle biopsy. Emergency management may include steroids or radiation for cytoreduction, but you have to be cautious because the biopsy may become uninterpretable in as little as 48 hours. In terms of evaluation for non-Hodgkin lymphoma, again, you take a history, you look for respiratory and constitutional symptoms. Again, B symptoms are not prognosis. You look for lymphadenopathy, signs of infection, signs of airway compromise. You can look at your CBC with differential inflammatory markers and a chem profile. You absolutely look for tumor lysis labs. You always do a chest x-ray to look for mediastinal involvement. You can consider a CT of the neck, chest, and abdomen, and you don't give empiric steroids. All of this can happen anywhere, like at your primary care office. Once you get to your tertiary care center, that's when you need your CT of the chest, CT or MRI of the abdomen and pelvis is standard. Most places will also get a PET scan because that may add some sensitivity to your staging. You want an excisional or incisional lymph node biopsy, and you're going to look at histology, flow cytometry, cytogenetics, and molecular studies. We do bilateral bone marrow biopsies and aspirates for this. And unlike Hodgkin lymphoma, we also do cerebral spinal fluid cytology. This is the St. Jude or the Murphy classification. It is different than the Ann Arbor classification that we use for Hodgkin lymphoma. And what is in bold here highlights the differences. So an easy test question is if you have an anterior mediastinal mass and it's Hodgkin lymphoma and you have no other disease, what stage is it? It's stage 1. But if you have an anterior mediastinal mass and no other disease and it's a non-Hodgkin lymphoma, you can see that that automatically bumps you up to stage 3. I won't read the rest of these, but this does highlight the differences. We use this staging as opposed to the Ann Arbor staging because pediatric non-Hodgkin lymphoma progression is not orderly and predictable like Hodgkin lymphoma. And so the Ann Arbor staging system does not adequately predict prognosis. There's a couple different risk stratification schemes. Most recently, we've used the FAB-LNB. And so stratum A is any completely resected stage 1 or abdominal stage 2. So this is the intussusception that you surgically remove and you find that you have a focus of Burkitt lymphoma in it. Stratum C is CNS positivity or greater than 25% blasts in the marrow. And stratum B is everything else. The BFM group also uses LDH to help risk stratify. So you can imagine the higher the LDH, then that increases your risk. In terms of treatment, in terms of the principle of pediatric non-Hodgkin lymphoma, there's some principles that are almost always true, and then there's always exceptions. So chemotherapy for all, with the exception of a completely resected pediatric follicular lymphoma or stage 1 nodular lymphocyte predominant Hodgkin lymphoma. CNS prophylactic for all, with the exception of a resected abdominal Burkitt or large B cell. Therapy is shorter and very, very intensive, with the exception of lymphoblastic lymphoma, which we treat more like leukemia. No radiation, with the exception of CNS positive lymphoblastic lymphoma, but even that's falling out of favor. Burkitt leukemia, we treat like Burkitt lymphoma. Lymphoblastic lymphoma, we have induction, consolidation, and maintenance, and the duration of therapy is at least 2 years. Survival is very high for all, even for the higher stage diseases. In terms of therapy, like Hodgkin lymphoma, it is risk adapted for all of the diagnoses, which means higher stage means more cycles and higher doses of chemotherapy. For example, a completely resected abdominal Burkitt needs 2 cycles of chemo, whereas a Burkitt leukemia or somebody with CNS involvement requires 6. Therapy is often response-based for Burkitt and large B cell. So we monitor response based on CT imaging, and we would do biopsy for any PET negative residual masses. If you have an incomplete response by CT and biopsy, you get more cycles of therapy and higher doses. So if you have a stage 3 Burkitt lymphoma of the abdomen, they should usually be in a complete remission after a couple cycles of intensive chemotherapy, but if they're not, we intensify therapy and give them 6 cycles. For all of pediatric cancer, you can get, this is a link to really good updated standards of care for pediatric treatment, which should not be the focus of the examination because that's such a moving target. And this is what the website looks like. It's also good because they have both they have patient-friendly as well as provider-friendly information on different pediatric malignancies. In terms of disease-specific treatment pearls, in terms of the mature B-cell lymphomas, rituximab has been proven to improve outcomes for high-stage disease, so stage 3 with a high LDH and all stage 4, and many people are using it for lower stage disease as well. For primary mediastinal B-cell lymphoma, treatment generally includes rituximab, but these patients in the relapse setting may also benefit from a checkpoint inhibitor. For anaplastic large cell lymphoma, we've learned that prolonged monotherapy with either brentuximab, crizotinib, or vinblastine can also result in durable remissions. So why our upfront cure rate is only 70-ish%, but monotherapy can have prolonged remissions is interesting. Lymphoblastic lymphoma, nelarabine reduces CNS relapses of T-cell ALL, and B lymphoblastic lymphoma, unlike B-cell ALL, relapsed B-cell lymphoblastic lymphoma has a very poor prognosis, and so CNS-directed immunotherapy may be an option, or CD19-directed immunotherapy may be an option. So one of the components of the different disease talks is to talk about the indications for stem cell transplant. Here you can see that most of the time we do bone marrow transplant for relapse lymphoma, it's in first relapse or second complete remission. The one that's a little bit challenging is anaplastic large cell lymphoma, because there really isn't a good standard of care. We know that we can have a good event-free survival of 50 to 67% with chemotherapy only. And we know that crizotinib, rituximab, vinblastine monotherapy can all induce prolonged remissions. There's probably a greater indication for the small cell variant, which is a higher risk, and maybe those patients need to be transplanted in their first remission. We also know that outcomes are better with allogeneic transplant versus autologous transplant. And there's the thought that there may be a graft versus lymphoma effect. These are the late effects of non-Hodgkin lymphoma, and like any chemotherapy regimen, they depend on the type of chemotherapy delivered. They're all listed here, and again, the alkylating agents tend to be the largest culprits. So lastly, I'm going to summarize the major differences between Hodgkin lymphoma and non-Hodgkin lymphoma. And if you take nothing out of this talk, take away these cheat sheets. These are the ones that I would use in my cramming sessions the day before the test. So one, these are the major differences between pediatric Hodgkin and non-Hodgkin lymphoma in terms of age, spread, B symptoms, whether or not we do marrow evaluations or CNS staging. These are a concise summary of the difference in staging between Hodgkin lymphoma on the left and non-Hodgkin lymphoma on the right. These are agents to know in 2021. These are very specific targeted agents that many of them are being used mainstream. I've listed each of the agents, the mechanism of action, as well as what disease you could potentially use them in. And finally, I realize the print is small, but this is meant to be a summary sheet that separates each of the different major lymphomas, the origin, the histology, the phenotype, the molecular translocations, the active target agents, and what are the indications for transplant. There's a couple of reviews that are available to you. And then special thanks to the pathologists and the radiation oncologists who contributed slides to these and prior talks that I've given. Lastly, this is a Saturday night transfer, 90-kilo child who's 13 years old, has orthopnea, shortness of breath, and an anterior mediastinal mass. My excellent fellow went into the room to talk about all the different kinds of lymphomas, and I went to the pediatric radiologist. This is actually a prominent, but nonetheless normal thymus in an otherwise healthy child. He had orthopnea because somebody asked, do you sleep propped up on a bunch of pillows? And he said, yes. The reason he does that is because he plays video games at night before falling asleep. Do you have shortness of breath when you run up a couple flights of stairs? We all do. So anyway, normally we would have a question and answer session, but thank you for your attention. Feel free to email me with any questions or comments or feedback that you have. Thank you so much.